Welcome, Dr. Matthews. He's an endocrinologist at Providence Endocrine and Diabetes Specialty Center in Trivandrum and investigator in phase 3 clinical trials of molecules in diabetes, osteoporosis, and growth hormone. Okay, you were the organizing secretary at ESSECON 2017 with lots of publications and presentations. So we're very keen to hear you, and the topic is very interesting, something that clinicians often do not do, and hence very, very relevant to clinicians here. The insights on medical nutrition therapy in Indian diabetics, analysis of the current evidence. Over to you, Dr. Matthews.
Yeah, thank you very much, Archana. I'm just trying to, someone has to let me share the screen.
Yes, please let's share the screen. Yes.
Yeah, I hope my screen is visible, Archana. And
yes, it's visible and you're audible.
Thank
Perfectly
you.
fine.
So I'd like to thank the organizers of this conference for giving me this opportunity. And I'll be looking into the medical nutrition therapy in Indian diabetics, and we'll look at the recent evidence. My talk is commercially supported by Sun Pharma, the makers of Prohance-B. If you look at overweight and diabetes in India, the data is quite alarming. This is a data which is there from the Global Burden of Disease, Injuries and Risk Factors Study 2016. And what it shows is that there is an alarming increase in the percentage of people who are overweight, and also in the percentage of people who are newly diagnosed to have diabetes. And if you look at what contributes to this increased risk of diabetes, you can see that the single most important factor for diabetes in India in this particular study is the overweight. So 36% of the diabetes disability associated life years could be attributed to the high BMI. And you can also realize that other important factors include the dietary risks and tobacco use and various other occupational exposures. And this is quite alarming. If you take things forward from 2016 and look at projections on how our risk of overweight and obesity will behave in India over a longer timeline, again realize that overweight is possibly going to double and obesity is going to triple in years to come. So we are dealing with a major public health problem in people who are overweight and obese. And we all know this, that obesity is associated with an increased cardiometabolic risk. And the risk is contributed by various risk factors which are associated with increased fat, which include increase in insulin resistance, glucose intolerance, inflammation, high blood pressure, dyslipidemia, leading on to endothelial dysfunction and type 2 diabetes. And all this together contribute to cardiovascular events, coronary artery disease, heart failure, arrhythmias, etc. So we are trying to tackle this epidemic with whatever measures that we can have. One of those factors which drive the overweight in India is the dietary pattern. And we have this study which is done as an observation study from various parts of India, which shows that it's called the START study, and it's authored by Dr. Shashank Joshi. You can see that wherever you sample from, whether it's central India, west, south, north, or east, you see that a significant percentage of the overall calories come from carbohydrates. And this is much more than the data that we get from Western literature. Again, large data sets, including more than 132,000 people, follow-up over 10 years plus, showed that an increase in white rice is associated with increased risk of type 2 diabetes. So they compared with people who are in the higher quintiles of taking white rice versus the lower quintiles, and found that especially in people of Asian Indian ethnicity, increase in white rice consumption is associated with increased risk of diabetes. And this is almost 60% increase. And compared to a standard diet or sort of ideal diet called the Eat Lancet reference diet, it has been generally seen that the affluent strata of our society consumes significantly more than what is required in terms of the calorie intakes. Now, looking at the other side of the problem, this is data from the ICMR INDIAB data to show how poor our physical activity is. So if you look at the picture on the right side to start with, you can see that percentage of people who don't undertake any recreational activity, exercise activity in the population is overall is quite high, more than 85% of patients. And you move up the elderly subgroup, more than 60% of people are supposed to do exercise in 60 plus age group, more than 95% of people don't have a recreational exercise activity. And this is not particularly seen in particular state. You can see that across various states, this data holds, showing that at both areas, we tend to have problems, both in terms of the diet and also in terms of the physical activity that we undertake. Now, coming to the second part, what are the sort of dietary interventions that we can do to produce weight loss? The general thing includes calorie restriction, that is to reduce the overall calorie intake while maintaining the proportion of macronutrients. You have various classification of reduced calorie diets. The low calorie diet and the very low calorie diets are the ones which are traditionally explained. The very low calorie diet is less than 800 and the low calorie diets are less than 1500. You could have a low carb diets with higher percentage of protein or fat. You could have low fat diets, or you could have low glycemic index diets. These are various dietary interventions to lose weight. And if you look at how these diets are implemented, mainly the low calorie diets and the very low calorie diets, in most of the trials, the very low calorie diets are almost exclusively based on meal replacements. And even the low calorie diets in most of the studies, at least 2 out of 3 or at least 1 out of 3 diet of the total major meals are replaced with meal replacement. So meal replacements are an important part of how we can formulate diet for our patients. Now, can we do it more naturally, just like most of our patients ask? Yes, there is some data to show that certain dietary interventions, this is a very beautiful study from Dr. Mohan's group, and which shows that if you look at brown rice versus white rice and legumes added on to brown rice, there's the 3 categories being studied. You can see that, and this is a continuous glucose monitoring study based on your dietary intake. And what they've done is they looked at the area under the curve for glucose excursions. Basically, it is asking how much of glucose does a particular meal increment, what sort of increment does a meal produce in terms of glucose. So what it is seen is that in comparison to people taking white rice, people taking brown rice have a almost 20% reduction in the incremental area under curve. That means a lesser glucose excursion which happens. And if you look at a combination of brown rice with legumes, it's almost 23% reduction in the area under the curve, showing that these are possibly dietary interventions, simple dietary interventions, which we can use in practice to reduce the sort of glucose excursions that we can see in our patients. And again, they looked at the change in fasting insulin, and they found that it's almost 50% reduction in the fasting insulin levels, which happen when you substitute one for the other. So these are all small informations which can help you manage the diet in clinical practice. Now, to just run through 2 important trials, large-scale trials of weight loss in people with diabetes. One is the Look Ahead study. This is again a very, very elegant study which has not got the real importance it deserves. So that is what I feel. So where they compared diabetes support and education, that is the traditional diabetes support and education versus an intensive lifestyle intervention, and whether that produces a diabetes remission. And what you can see is that year 1, year 2, year 3, year 4, the diabetes remission happened more in people who are following an intensive lifestyle intervention, which has produced more in terms of weight loss. And the direct trial, again, a very important trial of a total diet replacement in clinical practice in a primary care practice. This is from UK, the Dr. Roy Taylor's group. What they did is they replaced the diet with an 830 kilocalorie per day a dietary replacement called Counterweight Pro 800. gave around 2.25 liters of fluid per day. It's a nutritionally complete replacement with fiber supplements. And you can see dramatic reduction in body weight and a sustained body weight reduction even up to 2 years. And the study, it seems, is continuing to show benefits in the course of the trial. And the direct study also showed that more than 15 kg weight loss was obtained even in the year 1 in 24% of patients and year 2 in 11.4% of patients. And are close to 45% of patients in the first year and 35% of patients in the second year going on to diabetes remission. That means achieving A1Cs less than 6.5 without any medicines. Now, how did these trials achieve this? One of the methods have been meal replacements, and that is the subject of the talk today. So what is a meal replacement? A meal replacement is defined as a commercially available over-the-counter product. It could be a liquid, it could be a snack bar, it could be a shake, which is fortified with minerals and vitamins designed to replace 1 or 2 meals per day with at least 1 meal consumed as a normal food. So this is a partial meal replacement definition. And a total meal replacement means that you will replace all the meals and snacks with a replacement method, a meal replacement. So how does it work? It reduces the overall calories because you restrict the amount, you measure and restrict the amount of calories a particular meal can provide when you take a meal replacement. You replace carbohydrates with proteins. I showed you data that when you use legumes, you do have a reduction in area under the curve for glucose. Similarly, when you use proteins, you do have that benefit, and the proteins also are quite satiating. So you tend to consume less of calories. It provides generally adequate minerals and vitamins and improves satiety. This is the basic principle of how a meal replacement works. So always the question which can be questioned is that whether an isocaloric food replacement, a portion, can in fact, is it equal to a meal replacement? But studies have shown at least some data to show that even if you have an isocaloric food replacement, it does not equate to that of a meal replacement, and meal replacement produce better weight loss than isocaloric food consumed. I don't know why this happens. Is it the proportion of the proteins which differ or the fats which differ? But overall, meal replacement seems to be better in such studies. Again, large data sets are there, and overall, which shows that this is a meta-analysis show that in people who are overweight or obese with type 2 diabetes, a liquid meal replacement does in fact reduce various parameters of cardiometabolic risk, like adiposity, like glycemic control, blood lipids, and blood pressure. The majority of the benefits is in terms of body weight and BMI, and less in terms of the lipid levels, but overall a benefit. And if you look at partial meal replacements for weight loss in obesity, a partial meal replacement plan with an enhanced support, which leads on to a significant weight loss in people with obesity. Has studies used it? Yes, large studies like the DPP study, we know the Diabetes Prevention Program, use meal replacement as an optional intervention to increase weight loss. Look Ahead study, which I showed you, used a portion control meal plan to help patients adhere to their calorie goals. And individuals were encouraged to replace 2 meals, the breakfast and the lunch, with a liquid shake and 1 snack with a meal replacement bar. And the direct study I showed you, there's an area of total meal replacement which they have done. So all major studies of weight loss and diabetes remission do in fact use meal replacements. And is it recommended? We have recommendations by various organizations. I'm not going into individual recommendations, just to show you that the RSSDI ESI recommendation says that meal replacement, meal plans with strategic meal replacement, partial or full, can be an option under supervision when feasible. So this is also recommended. Now coming to the last part of my talk, this is to look at a commercially available meal replacement which we have in our practice, to see how it does in terms of a standard of care when it is compared against a standard of care in people with type 2 diabetes. So this is called the PRIDE study, and it expands into PROHANS-D targeting glycemic levels and weight control in type 2 diabetic population. Now, this is a multi-centric study which has been done in 5 cities. I'm not a party to the study, but I'm not an investigator, but I'm just trying to give you some details of the data. So the PRIDE data included people with diabetes, type 2 diabetes for more than 1 year, who are on stable oral glucose lowering agents for at least 1 month, with A1C between 6.5 and 10%, and a BMI between 23 to 34. The primary outcomes looked at glycemic levels, anthropometric measurements, lipid profile, and quality of life. The duration of study was 12 weeks, and the safety was looking at hypoglycemia and various adverse effects. And how they used it, they used 1 serving of PROHANS-D, that is the diabetes-specific nutritional supplement, that is 1 serving is 50 grams. And it was used before a major meal. That is a concept called as preloading. That means you load a protein ahead of a meal for lunch and dinner, or as a breakfast and evening snack replacement, and according to the physician or dietitian replacement at the study center. So this is how it went. Screened around 185 patients, randomized them into 2 arms, 88 in the PROHANS arm and 88 in the standard of care arm. You have a 6 weeks follow-up and a 12 weeks follow-up. And on the left side, I have put the PROHANS-D condensed. 50 gram is 1 serving, which serves around 225 kilocalories. 40% of the energy comes from carbohydrates, 17.8% from protein, and 38.1% from fat. Now, this is the baseline characteristics. The average age of the population is around 50 years. The BMI is around 26. Baseline A1C is around 8%, and total cholesterol is around 167. You can see the rest of the parameters here. And if you look at the study outcomes of people who are in the study, you can see that the blue lines show the 12-week data. The gray lines show the baseline data. And what is seen on the left side is a standard of care arm, and what is seen on the right side is the PROHANS or the test arm. And you can see there is a 0.6% reduction in A1C from baseline in people who were in the PROHANS arm, which was statistically significant. Now, if you look at the weight reduction, you have a 2.7 kg weight reduction in people at 12 weeks and around 1.4 kg weight reduction at 6 weeks, both in people who were in the PROHANS arm in comparison to the baseline weight. Reduction in waist circumference was also found, 1.17 inches at 12 weeks. And reduction in fasting plasma glucose from baseline also was seen, around 15.7 milligram reduction in fasting plasma glucose at 12 weeks. Reduction in postprandial glucose around 27 milligram per deciliter at 12 weeks in people who were in the PROHANS arm. And this is the overall compilation of the primary and secondary endpoints. One of the challenges which everyone faces while using meal replacements is the tolerance of meal replacement and the high dropout rate of patients who take meal replacement because of various things, because of the hunger, because of the overall lethargy. It can sometimes weight loss can produce lethargy, and the taste of the product is one of the most important things. Now, if you look at adherence, that means in terms of adhering to the diabetes treatment, overall group, a better adherence to diabetes-related medicines were found. Percentage of people feeling lethargic. Again, less subjects in the test arm felt lethargic in comparison to the control arm. And general well-being of the patients were also better in patients who were taking the supplement in comparison to people who were in the control arm. And overall satisfaction in the taste was moderate to very satisfied in a significant percent of patients who continued therapy till the end of the study. So this is again a summary of the QOL parameters. And if you come to the safety analysis, none of the patients had hypoglycemic episodes. No serious adverse effects were found during the course of the study. Just to summarize, meal replacement is a very effective method which you can use in your patients for both glucose control and weight management. And in this particular study, with a diabetes-specific nutritional supplement, the overall benefits in terms of primary outcomes of HbA1c lowering, fasting and plasma glucose lowering, in terms of anthropometric measurements, in terms of weight and waist circumference, was quite positive in people who were taking this supplement. And also for various quality of life measures, people who were on ProHands-D did better than patients who were on the placebo. Thank you very much for the patient listening.
Thank you, Dr. Matthews. That was very comprehensive. I just had a question, just a thought, that beyond meal replacement, do you use it in your practice in any other way? For example, as a travel or as a supplement to the meal itself in addition? As often I have seen consultants doing that. Do you see any role of adding it to the meal?
Travel, I haven't used. I think it's a good idea. That's a good idea to propose. But what we do is that most of the time patients don't prefer to have an entire meal replaced. That is one practicality in your practice, that people prefer to have a very, if you say partial, they would like to have it like a 50% of their regular meal with a meal replacement added on. That is very commonly used in the practice.
Do you feel that helps?
Yeah, that in fact helps. We have people who do that with one area which we have seen is, rather than the weight loss, a reduction in the amount of insulin people use. That has come down drastically when you do that. Yes, we do use it.
Thank you very much. Do you think they need a variety of meal replacements? And do you think they need different types of meal replacements? A variety or a single kind?
We for a particular patient, we use a single kind. We don't use a variety of replacements. We haven't tried that. But for different patient characteristics, definitely we use basically in terms of the different protein content of the meal replacement. But I don't want to mention any commercial names as of here.
Yes.
High protein replacements are done, especially for people who have more morbid obesity. But one practical challenge that I would always have felt is that higher the protein content, the palatability of the replacement is a big challenge. And the sort of gastric problems it could generate is a challenge. But some people, very motivated people, stick on to that. But we do definitely have follow-ups in people who can continuously use it. Yes.
Are there any contraindications to meal replacements?
Yes. To total meal replacements, yes. Meal replacements, because they have a reduction in calories and mostly the protein content is more than what we traditionally use. People with chronic renal failure, it's actually a contraindication for traditional replacements. You do have special replacements which they could take based on the quality of proteins they require. Then in general, people who are unstable in terms of their fluid status, congestive heart failure, people who are on diuretics to maintain their cardiac function, those are people we are very cautious about. In fact, we generally don't use it in them. We know that weight is an important factor, but still a bit cautious being an outpatient center. Yes.
So we have to be very aware of the contents of the meal replacement we are using and the right patient,
the medicines,
the right
Archana, regarding the medicines also, there are certain things like digoxin, carbamazepine, anti-epileptic drugs. So they may have a difference in absorption once you change the dietary pattern. So there also we are a bit cautious. This oral anticoagulants, stuff like that. Yes, we are a bit cautious there.
Right. So that's a point well taken. Thank you so much, Dr. Matthews. Thank you so much for this talk.
Thank you.